Hello everyone, welcome to MEDICA Cardio TALKS episode 23, and in this episode we are going to discuss the GLP-1 receptor analog semaglutide, which is arguably the most potent anti-diabetic drug. So I am thrilled to have today with me Dr. Dilip Pahari, who is the HOD of Nephrology at MEDICA Hospital, Dr. Tanmay Banerjee, HOD of Internal Medicine at our hospital, MEDICA Hospital. So to begin with, we all know how does semaglutide works. This is a GLP-1 receptor analog, and it is secreted in the gut by stimulus of food intake. It reduces the glucagon secretion. It acts on the satiety center, and it also slows the gastric emptying. So with these mechanisms, it very efficiently reduces HbA1c, and of late, amongst the CVOT trials, it has shown immense promise. So we have two large CVOT trials with semaglutide, one with injectable semaglutide, that is a Sustain 6 trial, and one is with oral semaglutide, that is Pioneer 6 trial. And the interesting part was Sustain 6, which was conducted over 2 years period, and it showed significant reduction in the primary endpoints, and which was largely driven by reduction in non-fatal stroke, and it came down by 39%. But we didn't see any benefit in terms of cardiovascular death or heart failure hospitalization. Coming to Pioneer 6, it was basically a non-inferiority trial which it met, but it didn't show superiority. And here we saw, in fact, cardiovascular benefits, reduction in cardiovascular death, but that was not the primary endpoints, and it was non-inferiority trial. So we have two large CVOT trials. So with this, we also have a insight and knowledge about from these trials that amongst all the GFRs, this drug works, and it reduces the total mortality. So now may I turn to Dr. Tanmay Banerjee. I think he has been treating diabetic patients for decades, and I would like to have his opinion. How do you feel that next couple of years it will entirely turn into diabetic patients with SGLT2 inhibitors and GLP-1 analogs as the chief primary drugs to initiate with? How do you see the future?
I think, as you said, that Sustain 6 and then Pioneer 6, those trials, they have shown definitely benefit, and new select trial ongoing at the moment. So this will be completed in next few years, 1 or 2 years, and we'll get more data about it. The bottom line is that diabetic patients, they are mostly type 2 diabetic patients are obese, they're overweight, and that is part of metabolic syndrome, what we call. So they also have hypertension and increased cardiovascular risk factors, including risk of stroke and myocardial infarction or an heart attack. So basically, we have been searching and waiting for a drug which will help in diabetic patients or even patients without diabetes but overweight and obese, where the drug will reduce the risk of cardiovascular mortality and risk of stroke and other complications. So many drugs have been studied, but I think this new drug semaglutide is quite promising as per the last 2 trial results. And also,
sorry to interrupt you, but what about your insight on the recent study which came up, STEP HFpEF trial, where non-diabetic patients with heart failure with ejection fraction, who were obese, more than 30 BMI, they were recruited, and it showed significant improvement in their quality of life and significant reduction in their body weight, also 13.1% too.
Yes.
So I think this is the only second drug after SGLT2 inhibitors which has shown significant benefit in heart failure with preserved ejection fraction. So what do you feel about, what is your comment on this trial?
Yes, I think that is promising, definitely, because as you said, the weight reduction was quite significant, almost 13%. There was reduction in NT-proBNP values, as well as in the increase in quality of life and 6-minute walk test endurance. So obviously, this is a drug which can also benefit patients with heart failure, even in non-diabetic patients. But the thing is that most of the studies, they have selected patients with a BMI of more than 30 or the recommendations would be that more than 27 with comorbidities. So they selected these patients with preserved ejection fraction more than 45%. So I think further studies will be needed in patients with reduced ejection fraction, but definitely this is a very promising drug.
I think I can add, actually we see a lot of patients with a heart failure with a preserved ejection fraction. So far there was no drug, and then after the SGLT2 inhibitor, it is the first drug which is approved for SGLT2 inhibitor as the first drug for with the preserved ejection fraction when the ejection fraction is more than 50. Second drug which has been recommended by the kidney authorities by KDIGO is the Finrenon, the MRI antagonist that's come as that. I think the recent trial by the GLP-1 analog, including semaglutide, is coming as a third drug which can improve the patients with the symptoms improvement in patients with the heart failure with the preserved ejection fraction. Whether this preserved ejection fraction, benefit is due to reduction in the obesity or the mobilization of the lipids from the different sources, the disposition of the lipid triglycerides and so on, or there is a reduction in inflammation and fibrosis, that has to be known. Further trials is ongoing, and then we can know the outcomes.
Right, sir. And I think, in fact, there was a very interesting meta-analysis which came up, which showed that diabetic patients, if we give different combinations like sulfonylureas with metformin and sulfonylureas with SGLT2 inhibitors, sulfonylureas with gliptins, and so almost all the combination which reduces the future hazard ratio, mortality, in 5 years is best with SGLT2 inhibitors and GLP-1. So how do you feel, how do you see this kind of results, and for renal outcome, I think for long years,
they are complementary. Actually, this SGLT2 inhibitor and the GLP-1 analogs, their actions is complementary. Both of them reduce weight, as well as both of them has a improved effect on the heart failures as well as the atherosclerotic heart disease, particularly triglyceride mobilization by the GLP-1 analogs and the weight reduction. Both of them reduces weight. So their actions are complementary. And in presence in the kidney, we have a more data from the SGLT2 inhibitors, but we are waiting for the results from the GLP-1 analog, whether they can reduce proteinuria, macroalbuminuria, and further composite endpoints in the kidney outcomes trial. So we need waiting for the results to come. The flow trial, which is for the semaglutide, which is going on, the results are expected in the end of 2024, and then we'll come to know what is the kidney benefit in patients with the kidney outcome, because most of the other trials, they have excluded kidney patients from their trial. So we don't know the primary kidney outcome. So the flow trial is the first trial of the GLP-1 analogs on the effects of kidney.
Flow trial we are all looking at. Can you throw a little more light on the design of the flow trial and what exactly you just showed? I just told we had in the Pioneer 6 and Select 6 study, 80% of these patients were either having cardiovascular disease established or were having chronic kidney disease. So there were some subset of patients which were really included in previous studies, but not a de novo all CKD patients. So can you tell us something about this?
The SUSTAIN trial actually has also shown that there is a significant reduction in macroalbuminuria in patients receiving semaglutide. So that's injectable semaglutide. So Pioneer trial also has shown the same benefit, and the kidney outcome is better. But the composite kidney outcome, so when the patient is requiring dialysis or going for transplants, when the eGFR is less than 15, that results are not available for the SUSTAIN or Pioneer trials. But that results are expected from the flow trial. The flow trial is designed in a group of patients. There are two groups of patients. One group, when the GFR is more than 50, means they have a almost normal serum creatinine, but they have a serious proteinuria, more than 300 milligram microgram of creatinine, albumin creatinine ratio more than 300. So there are patients who has got a severe proteinuria, but the GFR is near normal. On the other hand, the second group, when the GFR is less, actually is less than between 20 to 50, 25 to 50 show that they have a raised serum creatinine, and their proteinuria, however, is less, more than 100 by milligram per gram of creatinine, albumin creatinine ratio. So they includes the significant kidney patients with a variable range of EGFR, with variable range of proteinuria, and we are expecting the kidney outcome when they are going for the EGFR, I mean with the less than 15, when they are requiring dialysis, when they are requiring kidney death, and what is the degree of progression of proteinuria. All these will be known by the end of this trial.
I think it will really clarify the situation, and it can bring semaglutide in the guidelines if the results are positive.
So anti-obesity is the one of the hallmarks is the semaglutide. So people are now using the primarily anti-obesity drug, is much more popular anti-obesity drug, but we are looking for the cardiac and the renal.
Yeah. So with this thread,
Most importantly, I mean, apart from just losing weight, definitely semaglutide has shown some extra benefits, which is also being studied in the SELECT trial, like cardiovascular mortality. So they have selected patients of more than 45 years of age with previous stroke, MI, and peripheral vascular disease, and they're looking at an endpoint for cardiovascular outcome. So basically, it has also been shown that lipid profile improvement, which is independent of weight loss, and reduction in diastolic blood pressure, definitely, as we mentioned in the previous studies, decrease in cerebrovascular accidents and stroke. And
what about the dosing pattern, like 3, 7, 14 milligram?
Starting dose is 3 milligram orally to see the tolerance. So first 4 weeks 3 milligram, then you titrate the dose gradually up every 3 to 4 weeks after 14 milligram, which shows the maximum benefit, especially in terms of weight reduction and cardiovascular benefits. In patients with diabetes, as Dr. Pahari said, a lower dose may be effective depending on their diabetes control, or 2 milligrams subcut weekly, which will show has shown to be the maximum of maximum benefit in terms of cardiovascular risk factor reduction.
So Pioneer 6 trial very clearly, it has stated that it was one drug which was evaluated, for the primary endpoints. It was 14 milligram. So if we want a result or patient subset which we are, having as a prototype from Pioneer 6, we have to go to 14 milligram to get the same benefit.
Yes.
So with this, and I also must clarify here, semaglutide as of now is not recommended as an anti-obesity drug. Although we are getting, good results, just like in last trial, STEP FF, we saw a 13.1% reduction in, body weight, and we have seen multiple trials with semaglutide reducing weight, but still not a drug which has been recommended for obesity. Is a very, very, wonderful drug, multiple potentials. Finally, to conclude, this drug looks like have immense value. It acts on all the 8 pathophysiology which goes wrong in diabetes. It has a fairly good tolerance with a very potent anti-glycemic action, and of late we have seen a tremendous reduction in non-fatal strokes, and also in Pioneer 6 we saw some cardiovascular benefits, and finally the HFF trial was the first trial which showed benefit in heart failure hospitalization as well. So final 1 or 2 comments from Dr. Pahari and Dr. Tanmay, and then we'll wrap it up.
Yes. So I think this is this drug, what we call is the GLP-1 analogs, like glucagon-like peptide analogs, receptor analogs. So there are a lot of other drugs in the similar group. Actually, there is I'll not name the brand name, but there is another group of drug which is GLP analog plus GIP analogs. The GIP stands for gastric inhibitory peptides. If we combine receptors, 2 receptors, GLP-1 plus GIP-1 receptor analogs, then this drug is shown to have a significant effect on diabetes. It reduces the HbA1c up to 5.7. It's a significant anti-diabetic drug, and it reduces weight. And it is available currently even in India. But that's something different. Is a different is in the same group. But let's see how it comes.
Dr. Tanmay, last comments.
Yes, I think this is a quite promising drug. Definitely selecting proper patients, and we need to wait for the data from the ongoing trials like SELECT and FLOW studies. But at this moment, enough evidence is there that it has a definite cardiovascular risk factor reduction in selected group of patients. And as an anti-obesity drug is also very promising. You know, the surgery is the only other option which is shown to be of similar benefit, because this or maybe more benefit, but the side effects of surgery, bariatric surgery, is much higher. So this drug is quite promising in that aspect also, because we know losing weight definitely helps in reducing your cardiovascular risk factors, your lipid profile improvement, reducing your blood pressure and everything. So whether this drug is independent of the weight loss, that is what we are looking for. And I think this is quite promising so far in the trials, so far the results have shown.
So thank you all for watching it, and looking forward for episode 24. Thank you so much.
Thank you.